Good afternoon, everyone. This is Nirav Shah from the Maine CDC. We are just internet connectivity issues, so we will hopefully be loud and clear in just a moment. Good afternoon, everyone. I'm Nirav Shah, the director of the Maine Center for Disease Control and Prevention. Thank you all for taking a little bit of time out of your afternoon to hear the latest on where we stand with respect to COVID-19 for today, December 9th, 2020. And I'm saddened to begin today's update on a series of very sad notes. Just today, Maine CDC is reporting the deaths of seven additional Maine people. One of them was a man in his 100s from Androscoggin County. Another was a man in his 80s from Cumberland County. A third was a woman in her 90s from Hancock County. The fourth was a man in his 80s from Hancock County. The fifth was a woman in her 80s from Androscoggin County. The sixth being a man in his 80s from Cumberland County. And seventh, a man in his 50s from York County. 4 of these individuals died yesterday, and 3 of them died the day before, on December 7th. These additional 7 deaths come on top of 12 deaths reported to Maine CDC yesterday. Cumulatively, they bring the number of people in Maine who have died with COVID-19 now to 246. It's notable, looking at that list, that one of those gentlemen was a man in his 100s. A man who, though I don't know his exact age, perhaps was born during and even perhaps survived the last large pandemic in 1918. A man who survived the Great Depression, 2 world wars, numerous conflicts, to say nothing of numerous tumultuous world events, including potentially one pandemic. As we go into another holiday season, I ask all of us to remember the now 246 families across Maine who will be celebrating their first winter holidays without their loved ones. We as a state mourn their collective losses. And I would like to take a moment to offer all of their friends, family members, and communities our deepest condolences during this continuing time of grief. Overall, statewide, there are a total of 14,454 cases of COVID-19, an increase of 405 cases since yesterday. Of those, 12,678 are confirmed and 1,776 are probable cases. Overall, 10,388 individuals have recovered. As I mentioned a moment ago, sadly, there have been 246 deaths. Among our cases, 1,853 are among healthcare workers, and to date, the Maine CDC has now fielded almost 18,600 phone calls and requests for consultation from healthcare providers and everyday folks across the state of Maine. Cumulatively, since we began our pandemic activation, 819 people have been hospitalized. Just in the past 30 days, 252 people have been hospitalized. And right now in Maine, 173 people are hospitalized. 42 of them are in critical care, and 15 of them are on a ventilator. At present, right now in Maine, there are 84 available critical care beds. Turning to testing for just a moment, let's start with where we are with PCR testing. Our 7-day PCR positivity test rate is now standing at 4.7%, down just a little bit from a relative high of just about 4.9% a few days ago. Our PCR testing volume stands at 640 per every 100,000. To put the PCR test positivity rate into perspective, the national PCR positivity rate is upwards of 9%. We are also tracking our antigen positivity rate, which right now on a test-by-test basis stands at 5.28%, and an antigen testing volume of approximately 156 antigen tests for every 100,000 people. Turning now to some updates on outbreaks that Maine CDC has opened just since the last time we spoke. We've opened an outbreak investigation into the Enterprise car rental, where we are aware of 3 cases. We've also opened an investigation into the Pinnacle Healthcare facility in North Berwick, where we are aware of 5 cases. At the Seal Rock facility, where we are aware of 4 cases, and at Wyndham Middle School, where we are aware of 6 cases. Those are the outbreak investigations that Maine CDC has opened yesterday evening and this morning. Yesterday, during the day, there are 2 additional outbreaks that we opened that I'd like to report on. One of which is at the Lewiston Police Department, where we are aware of 16 cases, and at York Hospital, where we are aware of 4 cases. We've been working very closely with York Hospital, and they are undertaking universal testing of their staff to determine whether there are any other individuals among their staff who may be affected. Before I turn to questions for today, I wanted to take a moment to talk about where we stand as a state with respect to vaccines and vaccination. So I think we all know and can all sense a vaccine for this pandemic can't come soon enough. Right now at the Maine CDC, across the state of Maine, our plan focuses on vaccinating Maine's most vulnerable people, as well as the essential workers who care for them. Specifically, within the first few weeks of any vaccine being released, we are focused on distributing and vaccinating healthcare providers and hospitals, providers who work in, say, nursing homes, residents of those nursing homes, as well as our first responders, such as EMS clinicians. That's a broad group. Even within those groups, we are focusing first on healthcare workers with the highest risk of exposure to COVID-19. We don't know when a vaccine may be authorized, if a vaccine is authorized this week, but if one is authorized, we have been told that a vaccine may possibly be arriving to Maine in the days thereafter. Maine CDC has been preparing for months upon months for this day to come. For me, it's a bit like a relay race. We are ready to have Operation Warp Speed and the federal government pass the baton over to us. But as with any relay race, we've got to start running even before the baton lands in our hand. And that's what we've been doing for months now. But what I really want to talk about today is to set the table, to provide a big picture overview of what the promise of a vaccine holds and how we in Maine can set ourselves up for maximal success across all communities in our state. Let's talk first about what a vaccine will mean for the course of the pandemic. I think we all have this hope that the arrival of a vaccine will quickly bring an end to the pandemic, that the pandemic will go out the way that it came, with a resounding bang. I'm sorry to say that won't happen. The end of an outbreak, the end of a pandemic, is not like a switch being turned off. It's not like a fairy tale ending. We all wish that this vaccine would bring things to a quick and rapid close. But unfortunately, pandemics don't really end that way. Even after a critical threshold of people are vaccinated, sadly, the scientific reality is there will still be cases of COVID. That's because what a vaccine does is slows the rate of transmission through a population. Let me give you an example. Right now in Maine, for every 100 people who have COVID, they give the virus to, on average, more than one person. That's how outbreaks happen. So for example, for every 100 new cases of COVID on day one, those 100 people give it to, on average, more than one person. So we have about 110 cases of COVID a few days later, new cases. The way a vaccine works is to reduce that transmission rate, to bring the number of people that each new case gives COVID to hopefully below 1. But even in that world, it still means, for example, that for every 100 new cases, there still might be 70 or 80 new cases that they've given it to a few days later. Let me put that in perspective. Right now, the pandemic across the country and across Maine is like a speeding train. And by the time the brakeman pulls the brake on the train will still go for miles before it starts coming to a safe speed, let alone stop. It will be the same way with the pandemic. The reason I'm telling you this today is to emphasize that the good public health habits that we all have now may be things we need to keep with us for some time. Things like social distancing, physical distancing, as we like to call it, wearing a mask. Those good habits will not disappear even after a vaccine starts arriving. They will still be just as important. Indeed, as I will talk about in just a moment, they may be even more important. The other reason I'm telling you this is that it's important for all of us to be realistic about what a vaccine can do, and more importantly, when it can do that. Even after we start vaccinating the most vulnerable people in Maine, as well as those who care for them, which could start in a matter of days, if not a week or two, most of us won't see an immediate change, including me. That's why keeping up those public health measures that we've now grown accustomed to are so important. Now, there's a second thing that I want to talk about today, and that relates to how we in Maine can set ourselves up for maximal vaccine success. The bottom line here is that where you start with COVID determines how effective a vaccine will be. According to some recent research, any COVID vaccine will be much less effective at preventing death or illness if the vaccine is introduced into a population where the virus is already raging, which sadly is the case in many parts of our country. To put that differently, a vaccine for COVID is maximally effective when it is introduced into a community where the virus is better controlled. Where you end up depends on where you start. Going back to our speeding train, the vaccine acts like that brake. But if the train is already speeding down the tracks way too fast, that brake has much, much more work to do in order to be effective. What we can do now to set ourselves up for maximal vaccine success in Maine is to slow that train down as much as possible so that on the day, the week, the month that vaccines start being distributed, first to vulnerable folks and then thereafter, the slower that train is, the time that we pull the brake, the more quickly, the more safely, the more efficiently we will be able to stop it. The vaccine for COVID is the same way. Up until now, I've asked everyone to do their part and to do the right thing by wearing face coverings, by maintaining physical distance. Those asks, those recommendations are more important than now as the virus is raging across Maine. And I've asked people to do this to keep themselves safe. I've also asked people to do this to keep other vulnerable members of their community safe, parents, neighbors, those they work with. Today, I'm adding a third reason to do that. The better we get control of the virus today, the more success we will have with the vaccine tomorrow, the next week, and the next month. We all want a return to normal. We all want the economy and our schools to be open. And we all want to protect our family and friends from the pandemic. The bottom line is that the better we do now, the better we will all do later. Our finest medical researchers are clear. If we fail, there will be even worse consequences for our families and our economy. We all have a personal responsibility to slow the spread of the pandemic and eliminate the virus from widespread transmission as quickly as possible. And therefore, it's imperative that starting today, we take an effective, fact-based approach by doing the things we've talked about, like wearing face coverings and practicing physical distancing. Let's do what we can do now so that when a vaccine arrives, we are maximally prepared. I'll end with this. Doing these things and getting there will involve doing hard things. Doing hard things right now means potentially changing the way that we gather socially for our winter holidays. It may mean delaying a family gathering or putting into place a virtual gathering or phone calls. Those are undoubtedly hard things. Let's acknowledge that. Denying ourselves the comfort of gathering with our friends and family that comes so traditionally with the holidays. But if we don't do these things now, ourselves, our family members, our communities, and the success we may have with vaccination are all at stake. If we don't want darker days after the holiday, I'm asking everyone to do things today that will set us up for success, because what we do today impacts and predicts the success that we will have going forward starting tomorrow. So with that, I will turn things over to our colleagues in the media. And the first question for the afternoon goes to Joe Lawler from the Press Herald. Joe?
Sorry about that. Can you hear me?
Yep, I can, Joe. Go ahead.
Okay. So first, just a clarifying question before I get to the main questions. The 4,000 backlog, has that started? Have you started to go through that yet? Are we starting to see those in the case numbers, or will that be coming in the next day or two?
We started going through that on Monday. And right now, Joe, that backlog is one where we are trying to plow through it as quickly as we can. Sadly, the rate of new cases across the state every single day is exceeding what we are able to process. We have added more and more staff and have actually activated more staff from different places to start plowing through those. And the numbers that we are reporting now are reflective of working our way through that. But community transmission is widespread, and the virus is right now spreading faster than we can investigate new cases within that 24-hour window. We are making these changes and continuing to make them so we can plow through things.
So it may take a week or longer to get through the backlog. Is that fair to say? Or?
It is fair to say, and it is fair to say. And the last time we talked about a backlog was way back in March or April, maybe, when we were talking about it in connection with testing. And I want to be clear and on the record. This backlog is completely unacceptable. It's one that we know is not what Maine people expect. And I give everyone my commitment that we are marshaling every available resource. Every able-bodied person who can review lab results is now being repositioned to do so that we can move through the backlog as quickly as possible. But even though that backlog exists, we are still getting an increasing number of new daily reports every single day. Today, I believe I'll find the exact number, but we're working as hard as we can. I give everyone my commitment to that. But part of the reason we are experiencing this backlog is because of the extreme surge in new cases that we've seen just in the past 7 days.
Okay, thank you. And my follow-up question is, I heard from a medical professional that said that even though it's listed as having 84 available ICU beds, that there's a staffing shortage, and that is making that number a lot less, or even sometimes zero, and it's hard to find beds for COVID patients in intensive care. Have you heard about this? And is there anything, if so, is there anything that can be done to alleviate the shortage?
I absolutely understand that perspective, Joe. One methodology note first. That number comes from the reports that hospitals submit to us every single day, every 24 hours. And what we ask hospitals to do is not just count the number of beds they've got, we specifically ask them to report to us the number of staffed beds that they have available. That is to say, the number of true beds that could be filled by a patient if needed. So that number that we provide is not just the number of physical beds, but it's the number of staffed beds as well. None of that undermines or negates the fact that staffing is probably our primary bottleneck. Beds we've got, ventilators we've got. I can go through those numbers in a moment, but staffing remains one of our principal concerns, not just in Maine, but nationwide. But again, just to be clear, that number, what we ask hospitals to report to us is not theoretical capacity, but actual capacity, meaning staffed capacity. I'm going to turn next over to Emily Tadlock at WABI.
Hi, Dr. Shah. My first question is really just to get an update on a couple of outbreaks. I want to make sure we have the most up-to-date numbers. Deer Isle being the first one, and then Winterberry, Lakeview and Lincoln, and Flood Brothers in Clinton.
Okay. Just make sure. So Emily, because of the IT issue that we had, I will get you those. They are not in my notes at this exact moment, but we'll get those for you. I know we've got them. In fact, I will try to pull them to see if our IT system has gone back online. Let me just comment in general while I'm attempting to pull those up though. We've been working with each of the facilities that you outlined. One of the concerns, tying it to Joe Lawler's question, that has emerged in the last week or week and a half in these facilities is staffing. As folks will recall, one of the constants that we've seen in nursing facility and institutional outbreaks is the need for PPE, the need to conduct serial rounds of testing, so on and so forth. That's been a constant ever since we've been working with these facilities, going on months now. But in recent weeks, what has been new and what has been deeply concerning and alarming is the fact that many facilities are now running into challenges with respect to staff. And that's been something that our team across the state response has been really, really focused on. So let me get you the numbers right now. So with respect to Island Nursing Home, the current case count there remains at 90 cases. And I understand that they are doing another round of testing. So we should have some updated numbers there. At Winterberry, we are currently aware of 27 cases at Winterberry Heights. And the last one you mentioned was Flood Brothers Farm, where we are aware of 13 cases.
And then Lakeview and Lincoln.
At Lakeview, the current count there stands at 13 cases.
Okay, great. And then I have a viewer question, actually. Someone who lives, kind of directly next to Island Nursing Home. They're worried for them and their family being in such close proximity. Do you have any words that could help them understand better how this virus there can affect them living so nearby?
Sure. Based on everything we know right now, merely living in close physical proximity next door to a nursing home that's experiencing an outbreak, in and of itself does not pose any heightened risk. What we know is that the risk is a community-wide risk. It's not a block-by-block risk. The virus now has infected virtually every corner of the state. And so merely by being in very close physical proximity, i.e. next door or on the same block, that fact alone doesn't increase the risk. It does, however, it should, however, serve as a reminder for anyone to make sure that they are wearing face coverings, maintaining physical distance. What does increase the risk, however, is recognizing that we are dealing with community transmission. So it's not a block by block, street by street risk. It's an acknowledgement and a recognition that the virus is in every single community in Maine. That's the way we should be going about it. Even though their risk is not heightened because they are in close proximity, they should still behave as if anyone around them may potentially have the virus, because it is in all of our communities.
Okay, and then one last technical question. So the state lab informed Maine hospitals that they're no longer going to be processing their COVID-19 tests. Can you talk to us a little bit about why this is and what the strain is actually like? Are there any testing backlogs that we should be aware of?
There are no testing backlogs, but let me walk through those facts first, because I think it's really important. There were a handful of hospitals that were sending a high volume of samples to the Maine CDC laboratory. The Maine CDC laboratory is a public health lab, and it is focused on making sure that public health testing can be undertaken. Testing for outbreaks, testing at nursing homes for outbreak scenarios, the types of outbreaks that we talk about here. In order to be able to do that testing, which can vary in demand from day to day, we need to make sure we have capacity to do that. The other factor here is that hospitals have the ability to work with outside laboratories to ensure that their patients or their preoperative patients can get tested, but not necessarily needing to use the Maine CDC laboratory, which again, we are hoping to preserve for public health emergency functions like outbreak scenarios. So in light of that, in light of our desire to make sure we had sufficient capacity at our lab, as well as what everyone is aware of as an increasing number of outbreaks that we are opening day in and day out, we wanted preemptively to make sure that we had that capacity. Because we're opening more investigations, we want to make sure we can preserve that. The change goes into effect later this week. We recognize that it may be a challenge, but at the same time, we've got to balance availability for our lab for public health outbreak purposes.
Thank you.
I'm going to turn over to Evan at the Maine Beacon next.
Hi, Dr. Shah. Thank you. So California just announced that tomorrow they'll join 17 other states in using exposure notification functionality that people can opt into. That's developed by Google and Apple, that allows mobile phone users to know if they've come into contact with someone who's tested positive for COVID. And I'm wondering, with the current difficulty of contact tracing in Maine, does the state have any plans to adopt this technology or anything similar to it?
Evan, it's a good question. It's something my team and I have looked at periodically throughout the pandemic. What you will also have seen in the articles that covered that is that the experience of other states that have rolled it out has been uneven, to say the most. Virginia being the first state to have rolled it out, and their uptake has been, depending on who you ask, not what they thought it would be. And that's been the same pattern across a number of other states. The program does not work without someone's consent. It's not as if, again, that there's a switch at the Maine CDC that I flip and all of a sudden this entire thing happens. Folks have to agree to it. And what has happened in a number of states is that even though the state health department has signed on for this, individuals themselves have said, you know what, I don't know that that's for me, because of privacy concerns or other concerns they have. Even though the system does not track movement, it does not record names, individuals have had concerns. So the question for us is whether this is whether this should be our top priority right now, or whether it's something that we should continue looking at to see if there are ways to increase the uptake rate of it. It is not a substitute for contact tracing. It is just what it says. It is merely exposure notification. It is not a substitute for contact tracing. We're continuing to take a look at it. We have not ruled it out, but in talking with my counterparts across the country, the 16 or 17 states that have brought it online, what they've almost uniformly said is, we've rolled it out, but not a lot of folks in our state have really decided for themselves to switch it on. I'm going to just provide one really quick statistic, if I may, that struck me in a report that I read a couple of days ago about this. I will see if I can pull it up really quickly. But this is some data from North Carolina, which rolled this out not too long ago, and the CEO of the app company that developed North Carolina's app said that 91 of North Dakota's 14,000 active users had enabled this software on their phones. And of those 91, only 29 had actually decided to go ahead when they became positive to say, I would like to notify my contacts. And those 29 people only prompted 50 notifications. And that's as of, I think, Saturday or Sunday. We haven't ruled it out. The question for us is whether it's the most high priority thing we can be doing right now, or whether it's something we wait a little bit longer on.
Thank you.
I'm going to turn to Mal Meyer at WGME. Mal, welcome to Maine.
Yeah, thank you so much. Can you hear me all right?
Sure can, 5 by 5.
Okay, great. Talking about Portland Water District, they've been collecting wastewater samples to test for shedded COVID-19 particles. How are you guys using this from a state level? I know others are using this, like the University of Maine system. So how are you guys using this currently, and what's the hope for it for the future?
You know, the technology and the modality holds promise. And it's one that a number of communities across Maine have started using, as well as you noted, certain dormitories on, say, college campuses have used. In speaking with colleagues of mine, the question now is, of course, what to do with these data. What does it tell us from an action perspective? Certainly, the data are interesting from an academic perspective to look for correlations in wastewater increases and subsequent increases in cases later. That's certainly interesting. But right now, sort of in connection with Evan's question, our focus is on what can we do that will allow us to take action. One of the things that we found is that when the testing is utilized, say, at the discrete building level, say a dormitory, that empowers us to take action more quickly. This was actually the case in an outbreak from earlier this summer at St. Joseph's College, who saw an uptick based on their wastewater testing and worked with us to prompt widespread universal testing in the dorm. And I believe that we were able to identify an outbreak very early on before it got much worse. So that's what the discussion that we are having right now with colleges, universities, offices, as well as at the municipal level. We've been working with them and talking with them at length. And again, for us, the question is always, what can we do with this data that will allow us to make some intervention to protect public health?
Great. And then my next question actually comes from Blair Best. 14 people have died at Durgan Pines Nursing Home. Their medical director says 10 of them died from COVID, while 4 died from COVID complications. Can you explain what a COVID complication might be and why it's counted the same as a COVID death?
The way that we count deaths is the same way that virtually every state health department does, which is we ask a single question: did somebody die with COVID? It is up for, say, the medical examiner or a pathologist to make determinations of the cause of death. But what we do is we ask a simple question. As sad as all of these deaths are, our question is, did somebody die during the time period when they were suffering from COVID? Someone could, of course, still die after their COVID period is ended. That's a possibility. And a medical examiner may determine that COVID was a contributing factor in their death. We don't dispute that. The question we are asking, though, is not whether somebody, the question we are attempting to answer is a little bit different epidemiologically. It is whether somebody died with COVID. So there's no conflict in these numbers. They are just answers to different questions. That explains why, as to Durgan Pines, we have counted all of those deaths as COVID deaths, because they are the answer to the question, did this person die with COVID? I'm going to turn now to Steve Porter at Seacoast.
Thank you, Dr. Shah. I wanted to ask a follow-up question about York Hospital. You said that they are undertaking universal testing of their staff. On Monday, the hospital said it has implemented a plan to test all caregivers and patients who were potentially exposed, and the infectious disease specialist specifically said it was not universal testing, if I'm understanding her comment correctly. Did your team persuade York Hospital to conduct universal testing?
I will check with that, Steve, to make sure that that's where we are. We are aware that they have, as is standard protocol, notified any potentially exposed patients or visitors. But as to the universal testing, I will double check to see where we're at. Generally speaking, we recommend that hospitals cast the widest net as possible. Sometimes that does involve testing all staff, but it may be in this case that our epidemiologist, our medical epidemiologist, working with the infectious disease experts there, determined that it only needed to be certain segments of the hospital in our book, in my book, that still counts as universal testing. It need not be the entire medical staff, but it may be, for example, all staff on a certain ward or who provide a certain service. In our book, that still constitutes universal testing.
Understood. Thank you. And then also regarding progress on vaccination sites, do we know yet where all of those non-traditional vaccination sites may be? Do we have the funding to figure that out at this point?
So we are talking about community level vaccination, Steve. And I want to be really clear, that is months and months away. Vaccine may be arriving in Maine, theoretically, as soon as next week. But that vaccine will be housed at, for example, hospitals, or for use in hospitals or nursing homes. What you're discussing is community level vaccine, which across the country, as well as in Maine, may not start until the second, maybe even the third quarter of next year. We're right now planning out what the optimum locations for those sites are, and taking into account things like the need to have high throughput, as well as the need for folks to maintain physical distancing while they're being vaccinated. All of that requires resources. My colleagues across the 50 states and I have requested additional funding to come to all states to support that planning process. We'll get the job done either way. Again, that is what we do at the Maine CDC, but the more resources that we have and federal support that we've got, that will be all the faster we can get there.
And a clarification about that. Are there any non-traditional vaccination sites, such as local fire department or EMS services, that would be involved in the phase 1A high priority first round of vaccination?
Yes, so EMS clinicians are part of our phase 1A. Well, yes, they are part of phase 1A. So EMS clinicians would be those that we are looking to vaccinate. There are 4,991 EMS clinicians who are licensed and active in the state, and they are squarely part of phase 1A. Where they are vaccinated is something that we are working with the EMS agencies on themselves, but it's most likely that their site of vaccination will be at their station.
Thank you.
I'm going to turn now to Rosalind Flaherty at News Center.
Hi, Dr. Shah. Today, Massachusetts released its detailed timeline for vaccines. It has dates and it has categories to who will fall into those dates. When is Maine going to be releasing its detailed timeline?
I think we already have. We issued a release last week that specified where the first 1A group of vaccines will go. We're working on our planning for the subsequent week as well, and we intend to issue some type of communication about where those vaccines are going as well. Now, in terms of dates, with all due respect to Massachusetts, the US FDA hasn't granted an emergency use authorization. The Advisory Committee on Immunization Practices at the US CDC has not finalized their recommendations. So some of this does depend on where those things happen and the order in which they happen. We're ready to go in Maine. As I've mentioned, we have already started running before the baton has been passed to us, but having dates when we don't know when the starting line is or where that's going to be, that's not how we do it. We're going to be ready to go, and we're going to be clear with everybody about where and who we're going to be vaccinating.
Okay, thank you. One last question. 3 Maine healthcare systems held a presser earlier today. Basically, it was a plea to the public. How close are hospitals to either being full or overwhelmed at this point?
Well, I think if you heard those physicians, you heard it directly from them. Not only are the workloads and the burden that they are shouldering on behalf of all Maine people becoming something that is quickly becoming more and more difficult with each passing day, their challenges are quickly becoming the challenges of all Maine people. Now, right now, we're not aware that there are any of the health systems are, say, closing their doors. We still have, as we've talked about with Joe, over 80 ICU beds available, but we shouldn't take any chances in letting it get to a point that we are risking having the entire health system be in jeopardy. So I'd like to take a second to commend and applaud my colleagues in the healthcare system for making sure that everybody knows just how vivid of a problem this is right now in Maine. Literally nothing short of the entire capacity of the healthcare system is what we are contending with. So I'm glad that they put the word out there and raised the flag about what everyone in Maine should be doing. we've all got a responsibility to try to keep all of us safe. And as I talked about earlier, to try to set us up for success once vaccines become available.
Thank you.
I'm going to turn over to Steve at WMTW next.
Thank you, Doctor. Quick question about, well, as close as Rhode Island, we are seeing some states install some pretty serious restrictions heading into the holidays. So far, that hasn't happened here in Maine, but is there a tipping point where you would see some numbers or something that says we've got to pump the brakes here in Maine?
You know, Steve, let me start by saying all the options are still on the table. And I think as Governor Mills herself noted when she extended the 9 p.m. closure, more options, more steps may need to be taken. We don't have, as we've talked about during these meetings, we don't have a particular set point or threshold or a number that's on the wall here where if we go over it, then a number of things happen. We're taking into account a number of factors, one of which is the number of new daily cases, another of which, and the one that I'm paying more attention to now, or as much attention to now, is the number of hospitalizations. But Steve, we don't have a particular number. We're kind of doing a day-by-day evaluation to see whether there are other things that we can be doing. For example, our colleagues in the healthcare system have put out a plea for folks to wear face coverings. If that were more widespread, that's something that starting in a couple of days thereafter could make a sizable dent in transmission rates. So right now, that's where I think we should be all focused on. We at the state level, though, are keeping our options open depending on where things go. I will also note, Steve, that I think the cautionary measures that Governor Mills has put into place, as we take a look at them and how they rank or stack up against other New England states, when I take a look at those, I think we find that Maine is very much, well, in the main with what's going on in New England. So I don't see us as an outlier there, but we are continuing to carefully monitor. I'm going to turn over to Amy Brown next.
Thank you, Dr. Shah. I just want to first follow up and just clarify something you said earlier. You said if people die with COVID, they are counted as a COVID death, but if they die later after they've been considered to be recovered, even if the medical examiner thinks COVID may have contributed to the death, they are not. Just want to make sure I have that right. And then also, does that mean that if somebody died of, say, cancer, but they happen to be sick with COVID at the time, they're included in our number of COVID deaths?
Yes, as to both. And that has been the way we do it for all infectious diseases. And that is the way that, as far as I'm aware, every state manages this question.
Do you think at some point later, people may go back and determine that some of the deaths that COVID contributed to should be included in these numbers of this overall pandemic?
It's very possible. If the medical examiner, we could have a meeting with them, but it won't change again, the question we are asking is whether someone died with COVID. There are a lot of folks out there that are trying to minimize or undermine that number by saying, well, that person actually died of something else. The fact is, if you are suffering from cancer and you have COVID, that is almost certainly a major contributor to how you died. So we, again, are asking a simple and straightforward question, whether someone died with COVID. That's the way we have done it since the beginning of the pandemic. It's the way we do it for virtually every infectious disease.
Okay, great. I just wanted to clarify that. And a listener asks about whether or not people may still be able to transmit the virus after they've received the vaccine, either by being contagious for a period of time for the vaccine, which I understand does not appear to be the case, but if possibly they could contract the virus to some extent, and even though their body's fighting it off because they've been vaccinated, they may be able to infect somebody else?
That is a possibility, Amy, and it is one of the reasons why vaccines don't make infectious diseases go away overnight. It's possible that, and we will need the full complement of data to really be able to analyze this, but many vaccines don't necessarily prevent you from harboring the virus or bacteria. They just prevent you from getting sick with it, seriously sick with it. the data are still coming in and are being analyzed with respect to which of the different COVID vaccines affect the immune system in that different way. But that is one of the reasons why the arrival of a vaccine may not spell the immediate end of the pandemic. As I mentioned a moment ago, it's like that train. The vaccine is a very effective brake, but if individuals can still harbor the virus and potentially transmit it to others, it will still mean there will still be cases of COVID even after the introduction of the virus. The corollary of that is that the measures that we have all grown accustomed to, face covering wearing, face masks, physical distancing, may not go away for some time.
Okay, thanks.
I'm going to turn to Charlie at the BDN next.
Hi, Dr. Shah. Thank you. Apologies in advance. I have a little bit of a long-winded introduction, but I'll try to get through it quickly. So my first question, you and your colleagues at Maine DHHS have repeatedly mentioned small indoor gatherings as a big source of coronavirus transmission in the, this fall and almost into the winter. And then there are also some public health experts who have questioned just how much those events are causing the surge across the country, just because there's not a ton of clear research on it. So at this point, to what extent do you think those types of gatherings are driving Maine's surge, and what data do you have to back that up?
Sure. Let me start, Charlie, by noting that it's not just me at the Maine CDC. Much of this analysis comes from folks like Dr. Anthony Fauci, as well as senior experts at the US CDC, who have taken a look at the epidemiological data on a nationwide basis as well. Indeed, I was first clued into this epidemiological shift based on, it wasn't a talk or an interview that I heard Dr. Fauci give way back in early or mid-October. And that's when that light bulb first went off in my mind about this epidemiological shift that he foretold or saw in the data, and thus we started looking at it here. What we base it upon in Maine is the reports we receive from our case investigators who interview cases. And increasingly what we've seen since Dr. Fauci, and was echoed by Dr. Birx as well, raised this possibility for state health officials. What we've increasingly seen is individuals who say, for example, I have not attended a single large gathering. I haven't been to a single restaurant. The only place that I have been is to my friend's house last week, or my brother's house last Sunday, or having some friends over to watch the game. And that was a trend that we started seeing in the run-up to Halloween, but really more going into November. I'll see if I can better quantify that for you. But in my meetings with our epidemiologists, that was a refrain that we started hearing and seeing more. Folks who were, for all purposes, indoors, except for those social gatherings. A companion piece to that, although I don't have the data to prove this, but I believe it to be the case, is a companion piece to that, Charlie, which is individuals who, while they were at those smaller gatherings, less likely to be wearing masks. We ask people about their mask wearing behavior, but we don't always get the most robust data on that. So I can't give you a hard figure, but I believe by the reports that we've received that individuals are not just transmitting or acquiring it in small gatherings, but what is aggravating that is less mask wearing during those gatherings.
Okay, so I have one additional question, but first just to follow up on that. So in terms of quantifying it, it sounds like you don't have it at your fingertips, but is that something you'd somehow be able to do after this meeting, or that Robert might be able to do? I mean, I guess I'm just wondering how great that is a factor now versus 2 weeks ago, 4 weeks ago, et cetera. And do you have any sense of that, or is it more you're kind of triangulating a couple different trends that you're seeing, but don't have a clear sense of it?
It's the middle. So we are triangulating different trends. I think we've got a clear sense of it. You're asking sort of about the magnitude. And so that is something we can try to look into. I can't make any promises because, of course, our epidemiology team is outbreaks upon outbreaks, et cetera, et cetera. But let me take a weak version of your question and a strong version. The sort of weak-ish version is there reason to doubt the role of small gatherings in COVID-19 transmission? And there, Charlie, my answer is definitive. To me, the answer is no. On that, I believe the science and the epidemiology is settled. It's not just my opinion on that. Dr. Fauci and others share that same view. The harder question is, how do we quantify that such that we can get insight into how it's changed? That is a bit more challenging, I concede, because what has happened is folks are, their exposures outside of the home are growing fewer and fewer and fewer. So we're left with fewer venues at which they could get COVID as compared to March, where folks were still going out more. So that's what complicates that analysis. We'll see what we can do, but to be straight with you, given how swamped our epidemiology team is and how they're working now 18-hour days, I can't promise you. In fact, one of our senior epidemiologists, we had to put a rule into place that they have to go home. They have to leave the building at a certain hour every day because they were spending too much time in our building. So I'll do the best I can, Charlie, but I can't promise it.
Okay, fair enough. And then just secondly, it seems like it's getting harder overall for the state to keep track of all these chains of transmission, given that there are just a lot more cases, and there's the backlog you mentioned earlier and the recent change in contact tracing. I mean, at this stage, how important do you think it is to map out the precise ways that people are getting infected, or does it become less important when you're just so swamped?
I'm glad for that question, Charlie. So you started it by saying it seems, and I'll be more definitive. It is the case that the chains of transmission are blurry at this point. It resembles more that it's initially in COVID across the country, it was a series of straight lines, dots that we could connect. Now it's a bowl of spaghetti. That is the definition of community transmission. Community transmission, by its definition, means that individuals are being infected, but are not able to pinpoint where their source of infection was. That trend has been in place now for weeks and weeks and weeks, and preceded the changes that we've made. But those increases in community transmission have no doubt contributed to why we've had to make these changes, because they have caused and generated exponential growth. So I want to separate out a little bit one element of your question, which is the community transmission piece. That is certainly happening. There is no question about that. But that is not necessarily the reason for, but the changes that we have made do not necessarily complicate that picture. They are a result of that picture. Now, you asked a related question that my team and I and my colleagues and I have debated, which is what is the enduring value of these epidemiological interventions when community transmission is so widespread and rampant? And I think our view is that they still have value. Contact tracing, again, is not, what we're talking about is case investigation. They still have value because they allow us to see the light of potential outbreaks, which is something that we can intervene on really quickly, as well as communicating with folks who have tested positive so that we can give them advice on what to do and where to stay home. So we're not giving up. We think they have value, but certainly because of the onslaught of cases resulting from community transmission, that makes it very hard.
Thank you.
I'm going to turn now to Steve Missler.
Thanks, Dr. Shah, and thanks to Charlie for asking one of the questions that I had about contact tracing and the household transmission metrics, which leads me to the vaccination plan, which is pretty detailed. My question, though, is about for people who do not have organizational supports, who are not in congregate care settings. I'm thinking more of the phase 1B and maybe 2 folks. I'm talking, so people who don't have organizational supports or supervision directly, how will those people know when their number is up? How do you reach them?
Yep, and I don't think you meant to say when their number is up.
Well, no, I did not.
Yeah,
No.
yeah, I hear you. Understood completely, Steve. That's a challenge. So let's talk about 1B in particular. 1B, of course, is those who are essential or frontline healthcare workers. we will need to figure out a way to identify them, as well as to figure out what the best and most efficacious way that they can be vaccinated will be. It goes back a little bit to some of the questions earlier about sites of vaccination. It's possible as we get into 1B that some of the architecture we're setting up now around, say, EMS stations or places of that nature will continue to be the locations that essential workers may be vaccinated. We're also looking at maybe asking essential workers to go to their nearest Walgreens or CVS as a potential second venue there. But you're asking the equally challenging question of how we notify them. Most likely that will be through their employer, but that's a challenge. That's one that I know that 49 other states and territories are thinking through right now as well. It's going to be a challenge. But I will end by saying this, Steve. There's a notion that we've, how do I put this right? I'll go back to the favorite saying that there's this notion that the changes between 1A, 1B, and 1C are like those proverbial switches on the wall, and that we're going to switch off 1A and switch on 1B. But it's not going to be like that. It's going to be like dials that we turn down and turn up. So there will be a time at which we will be turning down 1A and simultaneously turning up 1B. So it's not as if we've got to have every single essential healthcare worker notified on Monday morning at 6 a.m. We will be able to turn the dial up as we move through 1B.
Thank you for that. Do you see a role with primary care physicians playing in this too, especially if they have somebody who might be on the, let's say they have asthma, but not like acute asthma, situational or something like that? Maybe the healthcare or their provider might be somebody who would they recommend it to them? Like, how does it work? How would that work? Or maybe we're too far down the road here. I don't know.
Well, no, you're asking the questions that we're talking about every day, Steve. So one observation is our operating principle is going to be that folks should get vaccinated in the highest acuity category that they are in. So if they are an essential healthcare worker who's 67 years old, they should get vaccinated in 1B, the essential worker category, not 1C. Primary care physicians, outpatient clinics will undoubtedly have a role to play. We've already started conversations with them. I've had some conversations with leaders of those clinics. We fully intend to support them first in their role as healthcare providers, 1A, but then also loci for vaccinations. The concern or the thing that we're grappling with is that we're talking about mass vaccination. So throughput matters. Some individuals may need that consultation with their physician before or during the vaccine process, but for others, it will just be about getting vaccinated. So throughput is really what comes to mind there. And so we're working with those clinics to see how they can maximize throughput as much as possible.
Thank you.
And the last question for the afternoon goes to Patrick Whittle.
Thank you very much. I might be asking you to speak outside of your job description here, but moments ago we received a notice of a one-time payment of $600 to certain workers who are unemployed due to the coronavirus pandemic in the state of Maine, which is a state program, not a federal program. Are there any more details that you can provide about this program and what the thinking behind it was? It seems like it's linked to the lack of a federal extension of similar programs.
Patrick, sorry to disappoint. I'm aware of the program, but I don't have any further details that would be illuminating or helpful, just to be completely straight with you. Sorry.
Nope, totally understand.
But anything else on your mind?
Tons of things, but I think we covered most of them in the previous questions.
Very good. Well, thank you all for taking a little bit of your time out of your afternoon to catch up on where we stand with respect to COVID-19. As I mentioned, just to recap, we are eagerly anticipating, preparing, and ready for the arrival of a COVID vaccine here in Maine. But I think it's also simultaneously important for us to be realistic about what that vaccine will do, when it will do it, and in whom. We all want this pandemic to end as quickly as possible. But we can take steps right now that will set Maine up for maximal success once the virus is introduced, not just for healthcare workers, but for essential workers, for older Mainers, and eventually for all Mainers. The number one thing we can do to set ourselves up for success is to slow the train down as much as possible before we pull the brake. The more we can do that, the more effective a vaccine will be once it becomes introduced into widespread circulation. So I ask everyone to do the right thing and to do their part. Wear a face covering, wear a face mask, stay physically distant, if not for yourself, if not for your vulnerable family members, then for everyone else in Maine to help set us up for success as vaccines start arriving. Thank you all so much for your time this afternoon. As always, please be kind, take care of one another. We'll talk again on Friday.